So welcome everyone to the Penn State College of Medicine Understanding Primary Immunodeficiency, a Project ECHO clinician education series. We're delighted to have you join us today. My name is Jackie. I'm a member of the ECHO team. I'm going to start us off with some quick announcements and introductions. If you've not already done so, please put your name and specialty or role in the chat, especially if you're logged in with a name that we cannot identify. If anybody's joining with you, we ask that you include their names as well. We ask that you stay muted unless you're speaking at any time. If you have questions or answers or information to share, feel free to unmute or use the chat to communicate. We absolutely prefer if you can use a webcam, but we understand that that's not always possible. Please remember that when we discuss cases, no personally identifiable information or PHI is allowed. We are recording these sessions for educational and quality improvement purposes. We share all materials after the session. In the spirit of Project ECHO's All Teach, All Learn approach, we're always on a first name basis during our sessions. So today we're going to have a brief talk on signs and symptoms of PI, and that's by Kristen Lutzkanin. And then we'll have a case discussion. One of our participants, Barb Bentz, is going to share a case that she's been dealing with, and then we'll have a discussion of that case. So again, during the presentation and the case, feel free to put your questions into the chat or to unmute. We do have a team of specialists online, and they're going to help field questions. But remember, it's all teach, all learn, so everyone can share questions and answers. So I'm going to just ask our hub team to briefly introduce themselves in case there were people here last week or 2 weeks ago who didn't get to meet them. So as I call your name, please unmute and tell us who you are and your involvement in this project. And let's start with Colleen.
Hello, everyone. Thanks for being here. I am Colleen Brock. I'm a registered nurse. I am the mother of 2 young adults with a primary immunodeficiency. I also have one, and I am the manager of medical programs at IDF.
Thank you. Megan.
Hi, everyone. My name is Megan Messick, and I'm the Director of Education at the Immune Deficiency Foundation. I'm new to the IDF team and excited to learn alongside you on today's session.
Thank you. Definitely the all teach, all learn approach there. Thanks so much, Megan. How about Ken? Oh, he might be on a call still.
Nope. Good morning. My name is Ken Bass, and I'm a patient with PI. Excuse me. I also am a support group facilitator with IDF here in Texas.
Thank you. Diana.
Good morning. My name is Diana. I am the mother of a child with PI.
Thanks for joining us. Paula.
Hi, I'm Paula Now. I'm a physician in allergy and immunology at Hershey Medical Center, and I'm part of the hub team.
Thanks, Paula. So, Kristen, I'm going to ask you to introduce yourself while Laura's getting your slides set up, and she'll advance as you tell her to.
Sure. Hi, everybody. I'm Kristen Lutzkanin. I am a pediatric allergist and immunologist here at the Penn State Hershey Children's Hospital.
And Laura, you can just advance through those first slides until we get to the content. Thank you.
All right, so I appreciate everybody being here today. And by the end of the talk, I'm hoping that you are able to describe generally when to increase your suspicion or when to suspect primary immunodeficiency in your patients that you're seeing. I hope that you'll also be able to distinguish between the different types of immunodeficiency according to the organisms involved and the locations of infections. So more so trying to figure out where your workup might be going based off the organisms and locations of infections, as well as to discuss other common presenting symptoms for primary immunodeficiency, as it's not all just about infections. Next slide. So I wanted to start off with just some basics. So primary immunodeficiency actually affects 1 in 2,000 live births, and that number is it's so commonly reported because that includes IgA deficiency, which in some patients is asymptomatic. So that number is shifted a little bit because of including those numbers. 80% of people who have a primary immunodeficiency are diagnosed under 20 years old. And immunodeficiency can affect any part of the immune system. And as I kind of alluded to, there's different patterns of infections and different types of organisms that can help you understand, or at least start to guide your workup for these patients to help you figure out if this is, an immune deficiency or if this is normal. Next slide, please. So we're going to go through the next couple slides will be when to suspect primary immunodeficiency in your patients. And the first thing to think about is infections that are too frequent. So you may wonder, what is too frequent? And so we consider that greater than or equal to 2 severe infections per year. Severe infections are typically infections that land a patient in the hospital, or patients that require IV antibiotics, or infections that are requiring multiple courses of PO antibiotics or oral antibiotics to improve it. Also, we would consider greater than or equal to 3 sinopulmonary infections per year to be something of concern. And in a patient who has had 2 lifetime lobar pneumonias, that is also going to raise your suspicion for primary immunodeficiency. Now, note that I said lobar pneumonia. Many patients will have atypical pneumonias or walking pneumonias, and those pneumonias are less concerning for primary immunodeficiency. If patients are needing antibiotics more than 2 months out of an entire year, that is when you should start to raise suspicion for primary immunodeficiency. Now, if a patient meets these requirements, of course, that does not mean they have a primary immunodeficiency, but it does mean that they deserve to have a workup. Most infections in patients with primary immunodeficiency present as routine infections. Sinopulmonary infections. So those are infections of the head, ears, eyes, nose, throat. So sinus infections, pneumonias, ear infections, those types of things. Most primary immunodeficiency infections are routine infections. Next slide. So if infections are too frequent, that's a concern, but also if the infections are too severe. 2 or more unexplained episodes of sepsis or meningitis, those would be concerning for a possible immunodeficiency. In the case of Neisseria meningitis, we say that 1 episode of Neisseria meningitis should launch in a workup for primary immunodeficiency. And then again, I kind of alluded to on the other side, the need for IV antibiotics and or hospitalization is what characterizes a severe infection. And you also want to take this into context. So if you have a healthy patient who presents with an episode of sepsis, that's different from a 80-year-old diabetic who's smoked for 20 years, who has a central line and then gets sepsis. You have to think about the central line being the source of infection and less likely immune deficiency. But these are all things that you have to think about when you are seeing patients. Next slide. So while we said most present as common infections for immunodeficiency can be unusual infections. And when you have unusual infections in otherwise healthy patients, you want to be thinking of immunodeficiency. So these would be like opportunistic infections. So if a patient presents with like disseminated histoplasmosis, that is something that would be of concern for a possible immune deficiency. Also, there's some kind of like buzzword bugs that if you see a patient, for instance, who presents with Burkholderia sepsis, or Burkholderia osteomyelitis or something, that patient has either chronic granulomatous disease, CGD, or cystic fibrosis until proven otherwise. So there's a couple bugs out there that are like clingers, and this is one of them where you like, that's not normal, that patient needs a workup. Next slide, please. So this is a sign that has been put out, and it just kind of goes through the numbers of, when to be concerned for immune deficiency. So this is something you may have seen out and about, but 4 or more new ear infections within a year. In the pediatric patients, before we jump to immune deficiency, we think more commonly of eustachian tube dysfunction. So that is a little bit of a qualifier there. And so eustachian tube dysfunction is more common in kids than primary immunodeficiency. 2 or more serious sinus infections within a year, 2 or more months on antibiotics. We already talked about that one. The pneumonias, number 4, they have that within a year, but honestly, if someone has had 2 lobar pneumonias in their lifetime, that should warrant an immune deficiency workup. Number 5 alludes to like failure to thrive or difficulty gaining weight. That's a concern. We'll hit a little bit more on 6, 7 further into the talk. We talked about the IV antibiotics, and then deep-seated infections like septicemia, 2 or more lifetime episodes of that would be concerning. And then a family history of primary immunodeficiency does raise your suspicion in a patient for primary immunodeficiency. But in and of itself, in a healthy patient, depending on the situation, you may or may not have to be doing an evaluation. It depends on the type of infection, of immunodeficiency itself. Next slide. So there are things other than infections that will raise your suspicion about a primary immunodeficiency. Severe eczema in a child is one of them. Failure to thrive in young children, even in older people as well. Chronic diarrhea and malabsorption is a big clue. Okay. Patients who have recurrent thrush or patients with unexplained thrush older than 1 year of age. And that 1 year of age mark is really important because we know pediatric patients are more likely to get thrush because they're breastfeeding or bottle feeding, and there's contamination. So they are more likely to have recurrent thrush. But if it's beyond 1 year of age, that should be concerning to you, especially if it's difficult to treat. Persistent lymphopenia on white blood counts is also an important indicator and a possible indicator of immune deficiency. A lot of times when we check our white blood or our complete blood counts and we get our differential, we often focus in on that neutropenia and those neutrophils. And sometimes the lymphocytes are left off to the side and just no one pays attention to them. But it is really important to pay attention to them because if they are persistently low, you should be evaluating that patient for further concern for immune deficiencies. We already talked about the family history. Patients who have history of early unexplained death in their family, they deserve workups for primary immunodeficiency as well, because oftentimes those early unexplained deaths, when you kind of delve into it more, could be due to immune deficiencies. Poor wound healing, wound dehiscence following surgery, those are other clues that you might be dealing with an immunodeficiency. Next slide. So there's several different types of immune deficiencies and they kind of present differently. So I'm going to go through broadly what signs or symptoms might clue you into certain immune deficiencies. And I know Dr. Horwitz did a great job kind of reviewing the immune system last week. So humoral immune deficiencies are deficiencies of the B cells and antibodies, and they're typically characterized by infections after 3 months of age. That's because your maternal antibodies, ones that you got from mom before delivery, they're starting to wane at that age, and you're starting to make your own if you can. And so these patients will present with sinopulmonary infections with encapsulated organisms. They may also be susceptible to enteroviral infections, giardia, so prolonged diarrhea, hence why that diarrhea and malabsorption is a clue. And they can also present with kind of unusual infections like mycoplasma and ureaplasma more commonly. And in most humoral immunodeficiency, they're not invasive infections, but they can be. Next slide. Cellular immunodeficiencies are immunodeficiencies more of T cells and K cells, natural killer cells. And these types of deficiencies are characterized by infections with intracellular organisms. And that has to do with the immunology that was reviewed last week. And so intracellular organisms are organisms like viruses, fungi, as well as certain bacteria like Salmonella and Mycobacteria. You're also more susceptible with a cellular immunodeficiency to opportunistic infections. So opportunistic infections being bugs that don't usually cause illness in a healthy individual. Next slide. Then you can have combined immunodeficiencies, and combined immunodeficiencies are immunodeficiencies of both the humoral side of the immune system and the cellular side of the immune system. And so because it's combined of both humoral and cellular, you get infections from both types. So you get the intracellular organisms as well, and the opportunistic infections, as well as infections with those encapsulated organisms. Combined immunodeficiencies can be mild combined immunodeficiencies, such as some patients with a CVID, common variable immune deficiency, may have some T cell defects, and so they will be considered a combined immunodeficiency, but that's more mild as compared to SCID, severe combined immunodeficiency, presenting in an infant. As you know, they have very different kind of presentations and different kind of severity. Next slide. There are also phagocytic disorders, and so these are characterized by either hot or cold abscesses, hot abscesses being abscesses that contain pus, cold abscesses being lacking of pus, as well as they can have bacterial and fungal infections in the respiratory tract, skin, and internal organs. For instance, CGD, chronic granulomatous disease, is something that you should suspect very highly when you see a patient who has like a liver abscess. In that patient, you're thinking CGD until proven otherwise. Poor wound healing is also a classic presentation for phagocytic disorders. So, and poor wound healing isn't like, oh, I have this scrape here and it's taking forever to heal. Like these are like wounds that stay gaping open, or they have surgery and they just, the wound opens up, within days of being sutured shut. It's pretty pronounced poor wound healing. And diabetics and smokers have poor wound healing, so you need to think about that when you're thinking through your differential. Does my patient also smoke and or have diabetes? Because that might affect your differential diagnosis. Next slide. Complement deficiencies also need to be considered, and they are characterized very specifically by the presence of sepsis, meningitis, and so especially Neisseria meningitis. If you have Neisseria meningitis, you are very concerned about a complement deficiency, and that patient needs a workup right away. Complement deficiencies, though, present with more than just infections and are often coincided by autoimmunity, specifically lupus. And patients with complement deficiencies also should be followed by cardiologists because they are at specific risk for accelerated atherosclerosis and early cardiovascular disease. So they need to be managed aggressively, typically with like cholesterol lowering medications to mitigate that risk. Next slide, please. So in summary, primary immunodeficiency should be considered when infections are either too frequent, too severe, or unusual. And the type of organism or the location of infection can help you establish a differential, whether that be a humoral immunodeficiency, cellular, combined, complement, or phagocytic. And that helps you determine what workup then to gather from your patient. Rather than sending just a wide slew of labs, you can really focus in on one particular aspect of the immune system. And while infections are a key part of immune deficiency, you have to have your eyes open to all of the other signs and symptoms, such as severe eczema, failure to thrive, poor wound healing, autoimmunity that can be associated with these, because sometimes in some patients, the autoimmunity will present first, or you'll have these little things like this patient has really bad eczema and they're a baby, so they don't have much history in terms of infections. So you just need to keep your eyes open to all of these things. And when your kind of buzzers go off, just think, is this something that could be an immune deficiency? Do I need to be more thoughtful about this? And that's my talk. I'm open to questions.
Thank you so much for that, Kristen. Does anybody have any questions before we move into the case? I'll give you a few minutes. Again, feel free to unmute put them into the chat. Kristen, there's a comment in here. I don't know if you can see the chat, but
yes, I do see it. And yes, delayed cord loss is a concerning sign for immune deficiency. I didn't want to get into the granular details because that's very specific for one immune deficiency, but that does fall into the kind of greater category of poor wound healing. And that is specific with a LAD, okay, like a lymphocyte adhesion defect. And yes, spatial dysmorphism does fall along with several immune deficiencies, and agreed about teeth and everything.
Thank you. And then there's another question. Can you describe specific risk factors for child severity?
I'm not sure I understand that question. Would you mind elaborating? In CVID.
Would you be able to discuss a little bit in verbally? That's
Okay, so CVID severity. Okay, so specific risk factors for CVID severity. I'm sorry, I don't know, Paula, do you have any insight?
I'm not sure. So perhaps described specific risk factors for CVID severity. So that's a difficult one to predict. CVID as you is a very common, so CVID stands for common variable immunodeficiency. I know we have a very heterogeneous group from some with very extensive knowledge of primary immunodeficiency and some with less knowledge. So common variable immunodeficiency is actually a wastebasket term for those that have a specific type of immunodeficiency that, as we discussed in the case last 2 weeks ago, have a combination of low IgG and or either low IgM or low IgA, and have a poor vaccine response. So within that, there is a whole heterogeneity of people that have CVID, some with extremely low IgG, some with moderately low IgG, some with profound deficiency and profound recurrence of infections, some with very mild disease. Some patients have profound autoimmunity with I've seen some with a celiac kind of presentation where they have almost like an esophageal manifestation. That's quite rare. More commonly, there are some GI manifestations where it almost is like a Crohn's manifestation of the GI tract, and it can sometimes be quite severe. There are other autoimmune manifestations. Some people I just with even to the point of retinopathy, I have seen. Granulomas is a big issue with either in the lungs, but can occur in the skin. And so there's a huge, vast component of common variable immunodeficiency. More and more, we've begun to recognize common variable immunodeficiency as a genetic disease, but only about changing all the time, but only about 5% have we found a genetic component. When we do find the exact gene, we do tend to say, oh, this is no longer CVID. Now we call it ICOS, for instance. And even though it meets all of the criteria of CVID, so the heterogeneity of CVID makes it a very complicated, very difficult disease. And that goes along with all of the diseases in medicine. You know, we don't even call it asthma anymore. Sometimes we call it asthmas because they're very heterogeneous, and CVID is no exception. But do we have predictors of which patient is going to behave one way or which patient is going to behave another? And we don't, unfortunately. Which patient is going to, here I have another question about C. diff infections. Which patient could end up having a C. diff infection? I don't have a predictor. Which patient is going to end up having more pneumonias and develop bronchiectasis? I don't have a predictor of that. So unfortunately, we tend to treat all patients with unfortunately very similarly, unless we have to treat the autoimmunity component, in which case we might make some changes. But for the most part, treat them at the onset very similarly, and then kind of go from there.
I agree. There's a very vast range in presentations for CVID. So it's really hard to describe any specific risk factors to help you figure out where they might fall, like where someone might fall. And someone who might seem like a mild presentation initially may go on to develop more autoimmunity. But it does tend to seem that patients who present with autoimmunity are typically more severe in terms of their CVID, but that's not the rule. And the genetics is playing an increasingly important role in helping us figure out who may be more severe, but it's still very unclear throughout the kind of scientific world as to that. I hope that sufficiently answered your question. I'm going to move on to the C. diff infection question. So C. diff infection as an infant is incredibly rare and incredibly difficult to diagnose because infants under 1 will test positive for C. diff, even if they're even if they don't have diarrhea. The testing for C. diff under 1 year of age is unreliable. And so sometimes patients will get tested under 1 year of age for having diarrhea and will be diagnosed with C. diff, but it's very possible that that's a false positive, meaning that the C. diff doesn't actually have anything to do with their diarrhea. So it is very difficult to kind of use that as a predictor for development of future immune deficiencies.
Kristen, I put that question in there, and the reason I put it in there was, although we knew at the time that he was already in trouble with his immune disorder, Adam developed C. diff and was extremely ill. I mean, extremely ill from it. And they were just at about the point of doing TPN and lipids and the whole 9 yards. He was not recovering. Finally kind of recovered, and then he got it again not long after. My reason for putting it in there is, should that be a red flag? Should a physician who's looking at an infant who is this sick with C. diff and gets it again, seemingly out of nowhere, wasn't on antibiotics, should that be something that is looked into?
I think anytime there is something that's out of the ordinary, or that doesn't seem, standard, or the normal response should serve as some sort of indicator that maybe further evaluation needs to be done. But I don't know of any literature to suggest that a recurrent C. diff is is an indicator of immune deficiency. But I think anytime that something is recurrent, you always have to have thought to say what else is going on here. But I don't know specifically in that case that I would necessarily think that C. diff in and of itself is a warning sign.
So thank you all for your engagement and participation. You'll be receiving an email shortly with a link to the session evaluation, and I will share participant resources once we pull those together. If you're claiming CME credits, you need to complete that evaluation in its entirety. But even if you're not, please complete it because it helps us to continue to improve our sessions to make them as beneficial for you as possible. And we will see you again on April 10th, and we'll be talking about steps to diagnosing PI. And again, please consider sending a case to us. We would much rather talk about your cases than the ones that our hub team has already been treating or working with. So thank you all. Any last questions, feel free to put them in the chat. We will address them in the summary, and we'll see you in 2 weeks. The hub team, if you would stay around, we'll do a quick debrief. Perfect. Thank you.